So.
Yeah. In addition to being in charge of the Allied Health Academy, she is the department chair for health science, so all you health science majors.
Public health.
And she also was, I guess technically still, I don't know, the part is on its way up.
Okay.
Yeah. Also co-PI for several other research projects. So with that, I will let her take it away.
All right. So I was very excited to hear that many of you are interested in public health. For those of you who may have mentioned another allied health career, yay, we're still going to convert you to have an appreciation for population health. And that really is what public health is all about, right? Learning to work not just with individuals, right? Helping and educating individuals to be healthier. But how do you work with entire communities and populations? Because we want to make the biggest impact on positive health that we can. Now, the ultimate irony for me today is I am a professor in public health, and I practice disease prevention, and yet I'm here today with a complete injury, a torn ligament in my ankle, which will prevent me from actually doing some of the demonstrations that we're going to be doing today. So instead, eat up, because I'm going to make you do some of the demonstrations. So what I do want to say is I'm a founding professor in the Masters in Public Health program here. And I have actually taught 2 of the core courses. One is an introduction to public health. It's usually just a very general, what are the major diseases, concerns in populations? How do we know? What are the general ways we address them? That's the first class. And then the second class is called Advanced Health Promotion and Disease Prevention. John is in this class right now. You can ask him afterwards what he really thinks about this class. The class is essentially a review of behavior change theories. So how many of you, I'll ask about people you know. How many of you know people who smoke? That should be nearly all. Okay, of the people, imagine in your head the people who smoke. How many of those people know that smoking's not really good for them? Okay, that's really everyone. So what does that teach you about behavior change? Everyone's like, oh, well, they don't know that they shouldn't do something. If they just knew it, they would change. Except for I had every single one of you raise your hands to say you know of someone who smokes, yet knows that smoking is not good for you. Yes.
My example is my dad. He smokes when he stresses. And my little sister always gets really mad at him, like really, really mad. And he's like, it's like, we tell him, like, it's not good for you, I even went to the Bodies Museum, and they have the lungs, someone who smokes cigarettes, and the lungs of someone who didn't smoke. And I took a picture and I showed him that. I was like, this is what your lungs are going to look like when you're smoking. And he knows it's bad for him. Yeah, every time there's something in the family that goes wrong, or there's a stressor either at work, or whatever the case is, he'll smoke one cigarette. I mean, it's not like a chronic smoker kind of thing, but he's still smoking, and he knows it's bad for him, but in his mind, he's like, I can stop whenever I want. So that's his kind of thing, like, I can stop it whenever I want.
How many of you, the person that you know who smokes, especially when they're around other smokers? There you go. Right? Or they smoke because it's a coping mechanism to something going on in their lives. Stress is actually a major one. Right? Okay, so exactly. In public health, we learn, first off, that knowledge does not lead to behavior change. Most people know in general what's good for them and what's not. So the idea is that you really have to learn much more about the ways, the theories that influence behavior change. The perfect example that you just gave is actually something called social cognitive theory. We're not going to go over it today, but just so that you know, there's a cognitive side, right? So he knows what to do when he does it. He really believes, he understands that it's not good for them, but he does it in a limited way. And then there's a social side. And in this case, it's sort of that stress, social stress side. And so this theory very simplistically talks about the fact that the individual and their social environment interact to lead to something like smoking. Or you can say low physical activity. How many of you know people? How many of you know people who aren't physically active? That should be all of us, right? Maybe some of us in the room. Not as physically active as they should be. And how many of those people know that they really should be physically active to be healthy, right? They know that. But there's all sorts of reasons why we're not as physically active as we should be. Social cognitive theory helps us understand that. So at the individual cognitive level, what do they know and understand? Those are cognitions, right? From psychology, intrapsychic element. And then from the social side, though, those are all the reasons. Well, it's easier to drive than it is to walk, right? What are some of those other reasons that people aren't physically active? What have you heard? Yeah.
Time.
Sure, lack of time, too busy. That's also the environment, right? What else?
It's too hot outside.
Oh, absolutely. It's too hot outside, or it's too cold outside, or it's raining outside. I don't know about you gentlemen, for ladies, if you're going outside doing physical activity, it's raining or it's humid, my hair goes south very fast, right? It's just not pleasant sometimes, right? So there's all sorts of reasons. And in public health, in the class that I teach at the master's level, you learn about some of these theories, right? You learn about these theories that help to predict why people are or are not as behaving healthy as they should be. Okay. However, so today, though, because I wanted to give you a taste and not a full mouthful of public health, what a master's level class is, I've really modified this. So I've actually de-emphasized the theory. Although, if you pay attention, I will refer to 3 theories or frameworks throughout this presentation. But I really wanted to take it a step back and talk about more, it's like a combination, more of an introduction to public health. Okay, so what you're going to get today is a taste of what I would do in my intro class, a little bit about what I would do with my behavior change theory class, and maybe, because there's a little program planning and evaluation in here, maybe what you would eventually do for your thesis or project, okay, as an example. Okay, and my area of research is in cancer prevention and cancer early detection. And so, hence, you get the glamorous topic for today, which is preventing cancer. So let's get to it. To get a sense from, what does the word cancer mean to you? Yes?
Hard to cure.
Hard to cure. Have other people heard this? Yeah, absolutely. And you've probably heard about the kinds of things that people need to do, right? Surgery, chemotherapy, radiation therapy, hormonal therapy, all sorts of different things. Okay. What else do people think of? Yes?
Most people think it could be like a concept, but there's sometimes just like, it just happens. Like you did the things not to, prevent it, but it's just in your, it could be, genetically.
So people are really questioning how they got cancer, for those people who do get cancer. Some people believe that they did something bad, right? There are a lot of belief systems that it's not just a biological belief system, right? Many of us believe in a spiritual, so that there must have been something bad that we did. Buddhists believe in a before life and an afterlife. Well, it must have been something I did in another life. Or you could be very biological and say, well, it must be genetic. I think I know what it is, right? My parents had it, or wherever I have a family history, that must be the reason why. But people struggle with the notion of how to, or what causes cancer. Now, does this mean that cancer is considered a really, of all the diseases you can pick to have, is this a good one? Okay, I'm looking around the room. Most people think like, right? So most people believe, well, I should say many people believe that cancer is still what they consider a death sentence. If you hear the word cancer, and I still have people, I do research all the time. I was just this morning at the Susan G. Komen Awards breakfast talking about breast cancer. And a young woman, age 27, stood up and talked about how she was diagnosed with breast cancer at a very young age. She didn't know why she got it, but she did take the genetic test, and she has one of the genetic mutations for breast cancer. It's called the BRCA gene. And that helped to inform what kind of treatment she would get. There was not a dry eye in the room, though, because people knew how difficult it was. She had surgery. She had 8 bouts of chemotherapy. She had 6 months of radiation therapy. So it was long. Most people then think that cancer is not a disease that you necessarily want to get, of all the diseases, right? And many people think it's an absolute death sentence. The general rule of thumb, though, with cancer is the earlier it's caught, the better. But we still have such a stigma about even talking about cancer. So then trying to get someone to go in and get to go through what we call screening exam, right? To find cancer early, they'd rather not know about it, right? So here's the push and pull. We want to promote people to get screened early. Education, get screened to find cancer early, because the earlier you find it, the more likely you are to live and live a healthy and happy life. But people feel it's a death sentence. So when people are possibly going to be told that they've got a supposed death sentence, they don't want to know. So promoting early detection for cancer is so difficult. I will show you, and I'm sorry for this being slightly blurry, but there are more than 15 million Americans alive today who have had cancer, right? That is a lot. You should know at least one person, and if you don't, it's probably not because no one has cancer. It's probably because no one talks about it, right? But more than 15 million. And this is according to the American Cancer Society's, their cancer treatment and survivorship facts and figures. And by the way, you will notice for every single slide I show you, there will be what is the source for this. And these sources are all research verified sources. So one thing that you learn when you're a master's program, there's no more talking generalizations, right? Everything you say has to be justified, cited, referenced, supported, right? Because we're based on, we promote critical thinking based on evidence. Right? Okay, but this is from the American Cancer Society. This is actually 2016, I think that says. And so if you think about cancer deaths, for men, what is the leading cause of cancer death in the United States? So that's the man, by the way. I don't know why that's the man. Oh, there you go, the hair. Maybe a breast, I don't know. Okay, so what's the leading cause of cancer death? Lung cancer, followed by prostate, and then colon. Okay, top 3. What about for women? Some is the same. Lung, and then breast, and then colon. So if you think about it, in the United States, there is a real commonality. The first and foremost is lung cancer. It is the hardest cancer to detect, right? And we still have a significant number of smokers in the United States. So it's a leading cause, because it's usually detected late, leading cause of cancer death. The second cancers are the sexual organ cancers, right? So for men, prostate; for women, breast. And then the third, though, is very common, colorectal. So there's a few things you should get from this slide. That's the first thing, that there's a lot of commonalities. But what else do you notice from this slide? Yes, Kim?
The leading one is something that you can prevent.
There you go. Okay, I love that. So prevention, we're going to get there in a second. But prevention is key. Certainly to lung cancer, the main prevention being stop smoking. Never start smoking, or if you do smoke, stop smoking. You see immediate results even after 1 year of stopping smoking. But what else do you notice about all of this? Let's say you're a cancer researcher like me. Is there a real clear thing that I should be working on? Maybe, if I want to go for the top one, right? But has anyone ever heard of esophageal cancer, leukemia, pancreatic cancer, urinary bladder, kidney, renal, brain? People have heard of these? Not necessarily, right? There's a lot of cancers on this slide. And what are they named after? What is the lung, the prostate, the colon, the pancreas, the liver? Leukemia is blood, right? The esophagus, the urinary bladder, the kidney. What are these? They're organs. Cancer is generally named by the organ it affects, not the type of cell. So there are many similarities in the cells that it impacts, but because those cells are together in a unique organ and the organs function differently, cancer is named usually after the organ. So what does that mean? That means that there are as many different cancers as there are organs in your body. Cancer is a multifaceted, very complex, and it's not just one disease, but it's many, many, many diseases. Hence another reason why, well, why did I get cancer? Well, there could be a lot of different reasons, depending on, issues regarding to that organ, that type of tissue, where it might be next to, et cetera. How cells grow in that organ, et cetera. So it turns out, for example, that the breast and the prostate have a lot of cells that are constantly being regenerated. And cancer is a genetic mutation. It tends to happen more frequently in certain kinds of cells than others, hence those organs. Okay. But we're trying to be hopeful today, right? Which means actually that what do we do in terms of cancer prevention? And this means not necessarily knowing how that cancer was caused. Are there ways to prevent cancer? And it turns out, according to Dart, Wolin, and Kolditz, that there are 8 ways. We talked already about one. What is it?
Screening.
Well, screening. Oh, I like that. That's actually the second one. We talked about smoking. Not smoking is the first. Getting screened is the second. There are screenings for which you can prevent cancer. For women, does anyone know? What screening are you supposed to be getting? Let's see. How many of you are 21 years and older? Sorry. There you go. The pap smear. So men, I'm sorry, you don't have a cervix. But for women, you have a cervix. Pap smear can actually detect a precancerous lesion, meaning it can prevent the cancer from even happening. Because when the cell is detected, that's precancerous, it can be removed. Okay, so don't smoke or stop smoking, get screened. What are the other 6 ways to prevent cancer? There's a hint. Think about ways to just being healthy.
Working out.
Oh, I love this. Look at that. Okay, wait, sorry. What did you say?
Working out.
Okay, physical activity. What else? Eating healthy, yes. Oh, good. Okay. When you eat healthy and you're active regularly, what about your body? Not necessarily lose weight, but maintain a healthy weight. So there's not an issue of an ideal weight, except for what we see in media, right? Which is always vastly different from what is considered healthy weight. But maintain healthy body weight. So that's 1, 2, 3, 4, 5. We got 5. What are 3 more?
Maintain the stress level count.
Oh, no, that's a good one that hasn't been shown to be related to cancer prevention yet. But I will say that inflammation is one of the biggest reasons why cancer occurs, and I bet researchers are going to go there. But there are 3 others. Anyone ever hear about the sun? What should you do when you're in the sun? Sunscreen, skin cancer. What about if you're drinking? Holidays are coming up. I'm sure you know a lot of people who are going to be drinking alcoholic beverages. It's not to not drink, but to drink in moderation. And the last one you may not think of. So here we go. What's the last one that we didn't think of? Number 7, sexually transmitted diseases. There are several cancers that are caused by viruses. Anyone know of any? I just mentioned the cervix.
Oh, the women get
Yes?
I forget what it is.
Is it for cervical cancer?
Yes.
So it's, there's a vaccine for it. Yeah, very good. Ooh, I like this. We even have a male, one of our men, because it affects the HPV virus also affects men as well, right? But for women, it very specifically causes cervical cancer. So here are the 8 ways. You will see that for most of them, they're actually just common sense, right? Do people know that they should be maintaining a healthy weight? People know that, right? Do people know that they should be only drinking alcohol in moderation? Most people know that. So these are, what's wonderful about the ways to prevent cancer is that they're generally universally understood. But people are still not doing it, right? Cancer is the second leading cause of death in the United States. The first is heart disease. And actually, many of these would relate to heart disease as well. So if we can just get people to have healthy behaviors, we would be preventing the top 2 causes of death in the United States. But the question is, how, right? As I told you, just knowing is not enough. Okay. I do want to also show you, for those of you who are health science majors, you might already know this, right? But it turns out that we're not going in the right direction. Most people know that, for example, having a healthy weight is important, but yet you look at the data from 1991 to 2010. The red, the darkest red, means that over 30% of that state, the population in that state, are overweight. I'm sorry, are obese, not overweight, are obese. In 1991, were any states over 30% of their population obese? No. 1996? No, but it's getting there, right? It's going from 10 to 14 to 15 to 19%. What about in 2003? What are the states? Can anyone name these states? Alabama, West Virginia. And then what about 2010? I'm not even going to ask you to name all of them. Right? I mean, and all of us have every state has at least 20% of their population obese. We know that maintaining a healthy weight is important for health. Everyone knows that. And yet we're going in the wrong direction. So it's not just promoting the healthy behavior, but in many respects, staving off what could be an epidemic of cancer, heart disease, diabetes that's currently in the works. There's been never a more pressing time for public health than today. Okay, so what I'm going to talk to you about, I'm cutting to the chase, and I'm actually going to show you a program we designed to try and promote physical activity as the leading #1 way to prevent cancer. This is actually something called Weaving an Islander Network for Cancer Awareness, Research, and Training, or WINPART. If you go into the Allied Health Academy office, you might see some things that are still referring to WINPART. We have a lot of things in there, a lot of materials. And the goal of it is to promote cancer education, research, and training among Pacific Islanders in Southern California. We've run this from 2005 and actually still to this day, 2016, although it's going to end this month. But in a good way. So first I want to ask you, anyone know who a Pacific Islander is? Or anyone have part Pacific Islander in your ethnic or racial background? Anyone ever been to the Pacific Islands? No? Okay. Anyone can name a Pacific Island? Samoa. Samoa, very good. Where else? Hawaii, absolutely. Anyone else? Tonga, absolutely. Oh, we can name a lot. Fiji, Tahiti, right? Guam. So it turns out that Pacific Islanders, there are, Southern California, is home to the largest population of Pacific Islanders in the United States. So there are, in the continental United States, not counting Hawaii. Back when we started this project, so this was back in 2000 when we were first looking at this data, there were over 200,000 Pacific Islanders in California, and nearly half of them are in Southern California alone. One of the things in public health we're very concerned about is who are the populations that have the most need. And we define need many different ways, right? We look at their disease, how often do they get disease, et cetera. But some areas of need are areas of need that other communities share. For example, are they getting access to education? This is what percentage of the population has less than a high school degree. And it turns out for groups like Tongans in California, 40% of them have a high school degree or less. 18% fall under the federal poverty line. 10% are on public assistance. 30% are what we call limited English proficient, or LEP. And we could be showing data for all sorts of different populations, but I want to give you a feel and flavor. We routinely look at demographic data for populations to get a hint at what might be some of their needs. Right? Low income, lack of access to education, these are important. And then we start looking at the health data. So we talked about lung cancer. So who has the highest rates of lung cancer death in California? There you go. Samoans, right? The rate is 72.6 per 100,000, followed by who? General Pacific Islanders, although that's a kind of a mishmash category, followed by who? Hawaiians, so these are native Hawaiians. Then, African Americans, then these are people from Guam. Generally, though, if you ever, I've often done this with my students, ask them to go onto the media and look at who the media talks about as being affected the most by lung cancer. You will generally not see any Pacific Islander. Yeah. Okay. And here is the Healthy People 2010 target. That target actually is different for 2020 now. So if you think about what we're trying to do as a federal government, none of these populations, right, including white, Caucasians, are as healthy as they should be. Okay, gives you an idea that Pacific Islanders have some needs, right?
So there's a Hispanic is really low, yet we have a really unhealthy diet, and like a lot of them smoke, at least that I know, so that's interesting.
You know what, I love it because you're questioning the data. So right now we know that Hispanics tend to have, even though a lot of people smoke, they tend to have lower smoking rates than some other populations, including Pacific Islanders. They have one of the highest, and African American. But Hispanics have also some other things that are changing as they acculturate, right? So smoking rates might be changing, right? Increasing smoking rates, and the idea that smoking rates might be staying the same, which is low, but other healthy behaviors are changing. And you mentioned unhealthy diets, maybe less physical activity. Absolutely. This may not be affecting lung cancer, but I would bet it's going to start affecting breast cancer. Here are the Hispanics. You can see how low, and when I say Hispanics, this is also kind of a mishmash of people, right? This is from many, many different countries. But you're questioning the data, and I think what you would be interested in looking at is not what we call prevalence. This is prevalence. This is a a snapshot. I think this is in 2004. I'm sorry, 1991 to 2001 data. But you'd want to look at trends over time.
Could it be like maybe they don't talk about it because a lot of people just don't mention it?
This is true.
Don't hide it, or they don't get tested, they don't have the patients to get tested.
Absolutely. So if a disease is undetected and someone dies from something else, like heart disease, you may not ever know that they had cancer, right? Very good. Okay, so this is breast cancer. So who's got the highest rates of breast cancer death? Non-Hispanic whites. I'm sorry, non-Hispanic blacks. In my one of my classes, I would actually explain to you why we go through non-Hispanic blacks or non-Hispanic whites. It's a purely governmental artifact of the many things that the U.S. government complicates. This is one of them. So I could just say black, but technically these are non-Hispanic blacks at the highest rate. But the second highest rates are Native Hawaiians, generally Pacific Islanders, certainly Samoans. And if you look at what the U.S. government goal is, you can see many populations are high. So have I convinced you that Pacific Islanders are a population we should be caring about? Yeah. I don't think I'll go through this. This is colorectal cancer. Okay. So if we just want to look at cancer and prevention, I already told you we're doing physical activity. But the question should be, of the top cancers that are affected in this population, Pacific Islanders, and here are the top 5 for males, top 5 for females, which ones are impacted by physical activity? Well, take a look at the ones that are bolded with asterisks. Each one of these has research showing that physical activity can either help prevent the cancer or it can help improve survival after being detected for cancer. So physical activity has some very important potential for improving what we do for cancer prevention and survivorship. Okay? All right, I think I convinced you now. Okay, so let's talk about a program that we developed and tested. Your task, and I'm actually going to make you do this, by the way, this program, in just a minute. But your task is to think critically. Okay? Imagine, number one, that you're in the Pacific Islander community. What could be the impact on you? And then, because you're all going to be health providers in some community, think about what the implications are for your communities, or the communities that you're interested in. So I believe all of you got the lovely reading, right? Okay, so this reading, Let's Move for Pacific Islander Communities, and Evidence-Based Intervention. So what does it mean when it says evidence-based? Yes.
Research and tested and validated.
Very good. So it's not just Sora, Tanjasiri going like, I really think we should do a video. That's a great idea. No. It's about looking at the literature and seeing what has worked in the past, right? And then figuring out how to adapt it for this population. That is evidence-based, right? And that's at a master's level what we expect from every single one of our students. So it's no longer just doing something because it kind of feels good or seems like it would be fine. No, show me the evidence that this has actually worked in another community before you adapt it for the community you're interested in. Okay, but the Let's Move had a really simple goal, right? It was to increase physical activity, but not just any physical activity. We weren't trying to create marathon runners, right? Or we weren't trying to create gymnasts or cyclists or anything. What were we trying to promote? It's right there. Very, very good. What we call short bouts or 10-minute physical activity breaks. Huh. Now, has anyone ever heard that you're supposed to just exercise for 10 minutes and that's supposed to be good for your health? Yeah.
Usually I hear like 30 minutes. Yeah.
Yep. So usually you hear 30 minutes for moderate to vigorous exercise, right? To be healthy. That is true overall. That's true in terms of weight management, weight loss, all sorts of things. But it turns out that research has shown with as little as 10 minutes of light to moderate activity, as long as it's regular, health benefits are immediately seen, regardless if you end up losing weight. So most of us, me included, do physical activity. My hair, right? I want to get some benefits out of this, right? To stay or to fit into my pants, etc. But when we talk about cancer prevention and heart disease prevention, short bouts have been shown to actually do the job without necessarily weight loss. This is a good thing, right? But we didn't just do it with everyone. We didn't just get a group of people in a park together. Who did we target? Pacific Islanders. And where did we target them? San Diego. Good, you're remembering some of these places. Hawthorne, Carson. And we targeted them in organizations. Right? So do people remember the list?
I remember it was like 3 that were church-based and then 5 communities.
That's right. So churches, right? Youth groups. We were targeting people in groups that they already, were members of. Because we wanted to get them, not necessarily because of the social cognitive, but because we wanted to teach them to do physical activity, but we also wanted to have the reinforcement, right? Because we knew that it's much more fun to do it together. It's more fun to remind each other, right? That would be much more successful, the evidence has shown. Okay, and the strategy, the way we did this is something called community-based participatory research. Hint, 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 this is one of those theories that if you were in the master's class, I would be teaching. And it's a certain kind of way of doing programs so that you're just not designing it at a university and then walking over to a church and saying, here, take this program, do it. It'll be good for you. But it's designing it together with communities. So researchers together with actually leaders from communities come together to actually adapt evidence programs for the community. And we did that. And I just wanted to impress you with the list of communities and organizations that we have worked with over the years to do this. And because there's no one person who has all the expertise, right? We worked with researchers from many, many local universities. And together, over this 10-year period, we created and tested many, many, many different programs. So CBPR tells us how to do this. And unfortunately, I'm going to shortcut it, and you're going to pretend like you're now all CBPR experts. And believe me that there's some very, very interesting ways that you can do this together. Okay. But let's cut to the chase. Let's Move had 4 components. And by the way, let me see where I am. It was evidence-based on 2 things. One is something called Tony Yancey's instant recess. So Tony Yancey was a researcher at UCLA who actually helped to disseminate the knowledge that short bouts of physical activity are good for us. She developed something called instant recess. She shared it with Michelle Obama. Michelle Obama, in part because Dr. Yancey and in part because of all the other research, developed what she calls Let's Move. Have you ever seen this on TV, on YouTube, et cetera? You see Michelle Obama doing her great moves. She can dance really well. To promote these short bouts of physical activity. Right? So Let's Move for the Pacific Islanders is based off of that literature. 4 different elements, though. So let's start at the end. This is the least important element, which is to actually lead regular exercise activities in these organizations. And we have something that I'm about to show you in just a minute. But that's not enough, right? Because we were just talking about the social cognitive. You need to change the environment as well, right? We're going to get people to really do what they already know is healthy for them. So we wanted to make environmental changes. We actually asked organizations to sign on. They signed on, and to make a commitment, they set a policy that they were going to promote physical activity at every one of their meetings. And then they actually put up posters. Some of them, we created this whiteboard and almost came up with like a little challenge for their members, right? So the members could put their names up and say how many times that they've done this Let's Move physical activity and make it a little mini contest, etc. So it's making environmental change by those posters, by creating that environment. Having that environment, that organization say, you know what, we pledge to promote this in every single one of our meetings. And most importantly, I just went backwards. The most important thing to kick this all off is finding not only the church, but the champion within the church who is going to make it her or his goal to get as many of the members, right, initiated and supported and ongoing as possible. So instantly you should be saying, yeah, this looks like a comprehensive program, not just changing individuals. Okay. We developed the 8 ways to reduce cancer, what we just talked about, and we translated it. We followed, I didn't cite it here, but Matthew Kreuter and his colleagues have developed a way to tailor materials for different populations. One of the most obvious way is what? Can you tell by looking at this? What did we do for each one of these? What did we do? Translate it. So at minimum, if a population doesn't speak English as their first language, this is sort of a no-brainer. You tailor it by translating it. But even if you couldn't, even if we didn't do that, just by looking at this, can you tell of anything else that makes you feel a little Pacific Island-ish? The colors, the images. This is perfect. So Matthew Kreuter and his colleagues talk about all of these kinds of ways to tailor it so that if you were a Pacific Islander and you saw these materials and you saw this poster, you would know it affects you. It impacts you without having to just say, this is for Pacific Islanders, right? Have you ever been to a doctor's office and you know that there's a brochure you're supposed to pick up, but you look at it and you go, doesn't look like that applies to me, right? I don't know how many times I've gone into the doctor's office and I see something, I'm like, oh, but there's no pictures of Asians. It mustn't apply to me, right? Because we have different risk factors, right, than others. So that use of color, of images, of even pictures, of language are all very important. Cultural tailoring is very important. Okay, we developed other posters, images, a DVD, it's actually now on YouTube. We gave out little incentive items to get, people in the mood for physical activity, and most importantly, we actually developed a short film. So you are now about to do this. Everyone stand up. And I will apologize ahead of time that I can't do this. Clear some room.